Thanks, everybody. I think my internet connection's unstable. It's flashing at me, so if I drop out, I do apologise. Next slide, please. So I'd just like to start by thanking everybody who was involved in this project, a number of clinicians all listed there, some from the previous summit, some new, specifically thanking Nora, Ella and Tyler from the data crunching side of things, and also Janine and Sam in particular from the VTS team putting it all together. But really thanks to everybody involved in the project. Next slide. We're going to give an overview of these areas, and I won't spend a lot of time speaking them out because we'll get to them, but a number of data points across the whole continuum. Next slide. Next slide. Yeah, great. So that's the optimal care pathway breakdown, the various stages of treatment and management across the spectrum of first diagnosis to end-of-life care, and we'll address some data points in each of them in turn. Next slide, please. The data that we have is linked data, and the Victorian Centre for Data Linkage is able to link these various admitted episode, radiotherapy course, emergency department presentation, so on data sets. They are all administrative data held by the Department of Health and really provide a very good overview of the administrative and population level data. There's some unlinked data sources, specifically the Cancer Service Performance Indicator Audit, that are specific granular medical record reviews. And then two registries exist in the state, the Upper GI Cancer Registry, which is a quality registry, and the Purple Registry, which is more focused on translational research. Next slide. The benefits of the linked data set are that they are statewide, and so you can see where patients start and finish in terms of different hospitals and integrated cancer services. It is population level data. It is limited by the lack of granular clinical detail and is administrative data, so it relies on hospital coding, which has issues. There are some assumptions. For example, the metastatic diagnosis is the presence or existence of metastases within 4 months of initial diagnosis, which clearly means they did have metastases at initial diagnosis, but has some discrepancies in patients having surgery and then 4 months later they've got mets and appearing to have had operations for metastatic processes, which is not the standard. And also the fact that Albury's not in Victoria makes that data point difficult to interpret. And next slide. The data is specifically presented in relation to pancreatic ductal cancer, which is 80% of all pancreas cancers, but the CPSI looked at all pancreas cancers, so including neuroendocrines and other variants. Next slide. The Purple Registry, which we've also got some data to present here from, is a network across Australia, New Zealand, Singapore. It's all stages of PDAC. It has some clinical and genomic data. It's primarily intended to be a translational research platform, as a number of trials, Dynamic Pancreas and Direct Inspire and others, leveraging off of it. Next slide. The Upper GI Cancer Registry is a clinical quality registry, so a different focus, is primarily Victoria and New South Wales, 60 sites, 4,500 patients or so, and that's got the data to speak to 26 quality indicators. Also leverages, or is also leveraged to run various trials, and was used to inform the National Pancreas Cancer Roadmap. So they're the data sources. Next slide, please. For those who are not aware, that the state's cancer services are grouped into regional and metropolitan integrated cancer services. They're the distributions. So clearly the regional ones cover much greater geography, and there are regional cancer centres within each, and cancer centres within each of the metropolitan ones additionally. Next slide. So now onto the data, starting with the demographics. This summit covers a 4-year period. The last one covered a 5-year period, roughly the same number of cases in both time periods. Same age, male distribution, same rate of metastatic disease at diagnosis, which remains close on 2/3 of patients with pancreas cancer are diagnosed with metastases. And that's a comorbidity profile based on the Charlson Comorbidity Index, which doesn't include everything, but it's a good surrogate. Next, please. There is a significant variation in the socioeconomic status of patients with pancreas cancer across the ICS, which really just reflects the socioeconomic status of patients within those ICS. It is an important measure to account for and correct for in the analyses, because it does have an impact on outcome. But you can see really quite dramatic differences in the socioeconomic status across the ICS. Next slide. Really don't have much data on prevention and early detection. Next slide, other than to say the incidence of pancreas cancer, which hasn't changed. The first dark purple dot is the previous summit. Oh, sorry, the grey dot is the previous summit, and the purple is the current data set. The age standardized incidence hasn't changed significantly from time period, and doesn't vary specifically from ICS to ICS, other than one outlier for some reason in WIC-MIX that we can't specifically explain. And it sits around the 7 patients per 100,000 persons in terms of incidence. All of the other error bars there cross that same level. So no specific difference in incidence across the ICS as far as we can tell. Next slide. In terms of presentation and initial investigation referral, next slide, we do have some data here that we didn't have at the previous summit, which is quite informative. It does show that there's quite a difference in where patients are referred to a health service from. Specifically, NEMIC see a lot of patients through their emergency department, whereas both SMICS and WIC-MIX see significantly fewer. And probably not surprisingly, in the regional centres, half of the patients come through the GP. Whereas in SMICS and WIC-MIX, half of the patients come directly from the surgeon's rooms. So there are significant differences in where patients are referred to across regional ICS in comparison to the metropolitan, and even within the metropolitan ICS. That's just differences in clinical practice. Next slide. That has an impact on the rates or the time between referral and date first seen. Obviously, those seen in the emergency department are excluded from this analysis because they're seen on the same day they were diagnosed. But even so, NEMIC sees patients remarkably quickly. But all of the ICS, including the regional ICS, see the median time between referral and being seen is within a week, which is great. And the vast majority of patients are seen within 2 weeks. There are a few outliers, which are probably statistical aberrations, of patients seen in one ICS and then sent to another ICS for a specific request or something of that nature. But the vast majority of patients are seen within 2 weeks, the median being within 1 week, which is just excellent. Next slide. In terms of the diagnosis, staging and treatment planning, the next phase of the OCP, we see no significant variation in METs by diagnosis or of ICS residents when adjusted for age, sex and comorbidities. The rates haven't changed from time period to time period or within ICS, as we've spoken to earlier. Next slide. But what is very different, and which led to the project which Anna presented earlier in terms of trying to standardise the resectability classifications, is the 2/3 of patients who are metastatic. It's standard across all of the ICS and regions. But if you look at the resectable group, or the non-metastatic group, I should say, separating those patients into resectable versus borderline resectable versus locally advanced is vastly different depending on where you are. And what you are therefore labelled and called, which is a significant variation and an unwanted variation, and really what's prompted from the previous summit the intention of introducing the synoptic report, or specifically at least the agreement on a statewide definition of resectability, because as you can see from these 3 different cohorts, just wildly varying rates of what's considered resectable, unresectable, borderline resectable, and so on. Next slide. That extends beyond just the data set which you look at and is again, vastly different depending on which ICS you go to, even within the metropolitan ICS. Really quite concerningly, the number of patients seen at a regional ICS considered resectable is very low. Particularly, for example, in comparison to NEMICS, where up to a third of patients are considered resectable. WICMICS, less than a quarter are considered resectable. Regionally, less than 10% are considered resectable. So dramatic differences in what's considered resectable, borderline resectable, and locally advanced across ICS and from region to metropolitan. That other chart, more centrally about the MDT meeting, really just demonstrates that if patients have metastases, they are much less likely to be discussed in an MDT, which is what we know and have identified as a problem, really. So really this slide and the previous one just underlines the importance of having a statewide definition of what's borderline, because it becomes very difficult to truly understand differences in outcomes from one centre to another if we're not calling the same thing the same thing. But hopefully we've addressed that now by agreeing on a statewide definition of what is borderline, and hopefully with that standardisation, the next summit in 5 years, which I hope to see you all at, should be better. Next slide, please. What is pleasing to see is there's very little variation, in fact, in the rates of surgery across ICS or the rates of chemotherapy across ICS, with virtually none of those lines crossing, all of those lines crossing the odds ratio of 1, meaning there's no difference. A little bit more variation in radiotherapy, but still not really statistically significant. Marginally different in BISWICS, for example. Marginally more surgery statistically in NEMICS, probably reflecting the fact that they call more things resectable. If you call more things resectable, you're going to resect more things. Again, it's probably a definitional thing more than anything else. If you say something's locally advanced, you probably wouldn't operate on it. If you call it resectable, you'll resect it. If we can standardise what we call resectable, then we should even that out some more. Next slide, please. As I alluded to in that preliminary overview of what's changed from one summit to the next, the top line is the 2017, the lower line is 2020. We're really still not hitting our target of patients discussed at MDTs. Even those numbers in the metropolitan centres are higher than we probably feel is true as a clinician group. We know that we're not discussing 3/4 of patients with pancreas cancer. We know that we rarely discuss patients with metastases. In fact, most of the patients who have metastases at the MDT are those that are unexpected. So we're presenting somebody who we think is borderline, and our radiologists say, actually, I think there's a big concern, something in the lung or a liver. Also a dramatic difference regionally, where it looks like nobody's being discussed, but I underline that that's probably just an appearance only, because this data is where they are first treated. Now, if patients are seen centrally and operated on centrally, or at least if they're seen centrally and recommended for chemotherapy, which they then have locally, they will be discussed centrally and treated regionally, and it will therefore appear that they're not being discussed regionally, although they are still being discussed at an MDT. So that's really just a perversion of the MDT process and our inability to track patients from hospital to hospital. There's the plug for CoolVic down the bottom there, which, as I mentioned earlier, as well as a better method of being able to track patients from one MDT to the next. So if a patient from a regional ICS is listed for an MDT at a central or a metropolitan ICS, that will be recorded and traced from one to the other. And CoolVic is, my understanding is that it is rolled out in all of the regional ICS and many of the metropolitan ICS, but really is a way to better understand this multidisciplinary cross-pollination where a patient is presented at one MDT and treated in another ICS. So I think really CoolVic should be commended for being a great initiative. But still the data shows we're not discussing everybody, and really we should be, because of all of that palliative care work and supportive care work, which we've heard about from our consumer groups and also from our own optimal care pathway, saying we're supposed to discuss everybody. Next slide. The Upper GI Cancer Registry furnished this for us, and it does show that, again, just reiterating the same point, many patients with metastases are not presented at the MDT. Only a third of those with metastases were, whereas 2/3 of those without metastases were presented at the MDT from that registry. Next slide. Supportive care is even more woeful. A formal screening process for supportive care screening, barely half patients are ever formally assessed with supportive care screening tool. I think in our defence, we do assess patients for supportive care at a higher rate than this, but we don't use a specific tool to do so. You know, part of a clinician's work is to assess a patient, and when we, in our history and examination, determine problems with nutrition or diabetes management, or identify social issues which need support, we automatically refer patients to the appropriate areas without using a screening tool. So I think this probably suggests things are worse than they are, and I think we do a supportive care screening process, but not using a specific tool. And I think it is an area where we can still do better. And I still hear patients find that the nutritional and sugar management issues aren't addressed as well as they could be, enzyme insufficiency and so on. So I think there are supportive care areas which we can improve on, and certainly the formal using of various screening tools which exist is very poorly documented. Next slide, please. In terms of treatment, if we can move on to that, this is really the nuts and bolts and the crunch of how patients are treated. So patients without metastatic pancreas cancer, there's a lot of information on this, so I'll step through it. The central column, about a third of patients have surgery who have non-metastatic disease, a third have chemotherapy or radiotherapy only, and then a further third don't have any active tumour treatment at all. And if we look at those groups, bottom right corner, most of them were elderly with at least one comorbidity or died soon after, which really reflects the fact that they were appropriately not treated because they were near the end of their life, and active tumour treatment within the last 30 days of life is not considered good quality care. Again, that third of patients who have chemotherapy or radiotherapy only, some of those will have locally advanced disease and are entirely appropriately treated. And some of those will have borderline disease that never come to surgery. And so when we have more information about their resectability status in a meaningful way, hopefully at the next summit, then we'll be able to speak to the appropriateness of that treatment. And then the surgery rate of 35% is slightly higher than previous summit, slightly more patients as a percentage going to surgery, but very importantly, one column back to the left there, chemotherapy, as I said in that preamble, 16% of patients are getting chemotherapy prior to surgery now, which comes down to 65 patients out of the 400 who had surgery, which still over 5 years or 4 years isn't me, but it is significantly more than the handful of patients who had chemotherapy prior to surgery in the last summit. So I think this is a real change and an important change, and really does mean that more patients are being given systemic therapies, which I think is very important. Again, as I said in the preamble, in that fourth column along, the rates of patients having chemotherapy is fairly similar. About a quarter of patients do not get therapy following surgery for various reasons. There has been a change away from radiation, much fewer patients getting chemoradiation, which is probably in line with the data suggesting it's not the most effective adjuvant therapy. But that's really where we are regarding the treatment for non-metastatic patients, and some certainly improvements from previously. Next slide. This will discuss the metastatic patients. And again, as per previous summit, very bottom in that central column, about half, in fact, more than half of the patients who have metastatic disease are not given any active tumour treatment. Again, many of them are elderly with comorbidities, die within a month of diagnosis, but that's 1,000 patients. And this entire cohort is 3,000 patients. So 1,000 patients of the 3,000 in the cohort do not get any active treatment from medical oncology or surgery, really underlining that palliative care and supportive care is a very big part. They're the primary clinicians, you could argue, treating this disease. I totally appreciate the perception that the consumers brought up that palliative care is seen as end-of-life care, which is part of the treatment, but I think reframing it as care plus, as Jenny has done in that fantastic work, is a great step forward, because, and ironically, palliative care is a renaming of what was previously known as hospice care, which was changed from hospice care to palliative care for the same argument, that it's seen as the end of life. So, the cycle continues, and now palliative care is associated with being the end of life care, which it's not supposed to be. It's supposed to be that supportive care. So I think that this slide just highlights how important palliative care is. Surgery slide, 40 patients out of 2,000 had surgery. That doesn't strike me as a major problem because of the definition that pancreas cancer, that metastatic disease is within 4 months. So some of them will have Mets 4 months within their surgery, unfortunately, and fit into that category. So that's the state of play with the treatment pathways for metastatic disease. Next slide. This is a busy slide with a lot of data, which is of variable use. I hesitate in some ways even to present it, because it is an easy target for Let's Do Better, but probably isn't a meaningful one, because the time course of 28 days to treatment is problematic, because when does a 28 days start? Does a 28 days start when they've had a CT scan, which suggests there's a pancreas cancer, or does it start within 28 days of having a biopsy, which may or may not be positive, or exactly when? So there are problems with this sort of analysis. It shows that probably most patients are treated within a reasonable time frame, certainly more than half for most of the time. Certainly for those who have neoadjuvant therapy, 70% in the previous summit, 60% now. But as I say, I hesitate to focus on it because there are problems with interpreting this, because it's so hard to really know when to start the clock. Next slide. What is good to see is that the length of stay has stayed fairly standard. It is a long time in hospital. You know, the median length of stay is 14 days. And I say that to patients frequently for expectation setting. And I also refer to cardiac surgery. You know, patients have a concept of the size of open heart surgery, but the length of stay for open heart surgery is 5 days. As a standard, and the length of stay following pancreatic duodenectomy is 2 weeks. So that really frames patients' perception of what they're facing when they have a Whipple operation. It is interesting that the median length of stay is longer in the regional X. Hey, I'm just on the phone, okay? There is a significant difference between regional and metropolitan. Probably partly because of the fact that we've got very broad areas which are covered regionally. And so it's probably reasonable that patients aren't sent home or are sent home when we are entirely sure they're well, rather than trying to make an early discharge. But that is a difference. And although there are only small numbers of patients having Whipples in BISWICs and GICs, they fairly unequivocally have a longer length of stay. Next slide, please. Looked at as a funnel plot, you can see that most of the patients are within that central funnel. There are patients who are seen primarily in BISWICs that are outliers on that funnel plot. Can you just... Sorry. There are a few also outliers in the other direction who would go home sooner, which is good too. Next slide, please. This was interesting data from our previous summit on the top line, and then the current summit lower down. There is a long tail for pancreas resections. There are a lot of patients, a lot of sites that are doing it at very few times per year, which is a problem. But pleasingly, the tail has shrunk. It hasn't changed in private, although the median volume has doubled in private. but the tail in public has reduced from 23 to 17. That's for all pancreas resections and all indications. Next slide, please. If we just filter it to the Whipple resection, which is a major one, which patients are in hospital for 2 weeks. Again, no difference really in the private hospitals or public hospitals either, other than to say probably more workload is being done in private now. The median volume in the previous summit private was 4 cases. The median volume of these centres now is 13 in private. So, and that's these numbers, 10 or 13, are reasonable for a reasonable volume of Whipples per year. It's still low volume compared to the rest of the world, but that's the state of it. It is still interesting and arguable, perhaps, that there's 22 places in Victoria doing Whipple resections, but that's the nature of the beast at the moment. Next slide, please. In terms of surgical mortality, it is absolutely world-class. 30-day mortality and 90-day mortality of 2% in the current cohort is genuinely world-class. As I said at the previous summit, for comparison, the US data would say that the 90-day mortality following this operation is 9%. So we are well below the world average. And the funnel plots there show there's no outliers, and there's very low numbers of patients that are dying following the surgery, which is fantastic because it is a major surgical endeavour. Next slide.
Okay, so thanks, Charles. So, Charles, there's a couple of surgical queries in the chat. If you could respond to them, people have raised. So we have seen an evolution in chemotherapy treatment over the last decade. So 10 years ago, really, gemcitabine monotherapy was the only agent available for either metastatic or adjuvant setting. We've seen changes since then. So increasing use of gemcitabine-based doublets, GemCap in the adjuvant setting, gemcitabine Abraxane in the metastatic setting, and of course increasing use of FOLFIRINOX. So we don't have specific data on what regimens are being used, but we can to a degree infer this from the schedule of these agents, with gemcitabine given weekly, or gemcitabine-based therapy being given weekly, and FOLFIRINOX on a fortnightly basis. And you can see the implementation of improved chemotherapy regimens into practice, with maintenance of gemcitabine-based regimens and an increase in 5-FU-based regimens over time, presumably reflecting increased use of FOLFIRINOX-based chemotherapy. Next slide, please. Similarly, we're seeing the implementation of new regimens based on the Purple registry. So from this data set, so this goes back to 2015's 32% of patients receiving adjuvant gemcitabine, but increased use of GemCap, so gemcitabine-based doublet, and 23% of patients receiving FOLFIRINOX-based chemotherapy. And it's likely we're going to see the trend to increasing use of FOLFIRINOX over time. Next slide. Similarly, again, we can see the trial data is leading to a change in clinical practice. So following SPAC4 data, increased use of gemcitabine and capecitabine as adjuvant treatment. Similarly, following the PRODIGE data for FOLFIRINOX, an increase in use of FOLFIRINOX-based chemotherapy, and generally across the time, which was an observation that people have noted in the small groups, an increasing use of preoperative chemotherapy. Next slide. This is outcomes again from the Purple registry. So for people with localized disease, surgery attempted in approximately 32% of cases. So generally, I think a demonstration of a reasonably aggressive surgical approach, and surgery completed in 28% of the cases. Next slide. So then if we turn to sort of outcomes after care, next slide. So this is a forest plot of overall survival. So if you look at the state, we've seen a small increment in overall survival. This is so 1 year adjusted overall survival, 30% in the previous cohort, increased with a small increment to 32% in the current cohort. But nevertheless, the reality is it's difficult to shift overall survival, of course. So and generally gains do tend to be incremental. This is a forest plot of the overall survival. You can see again the same consistent pattern. The current cohort is in purple. The previous cohort is in grey. And what you've got is everything is compared to the statewide average. If your hazard ratio is greater than 1, then that indicates a worse overall survival. Hazard ratio is less than 1, indicates a better overall survival. And then what you see is the mean and the 95% confidence intervals. And you can see that for most of the X, whether we look at the previous cohort or the current cohort, that the 95% confidence intervals cross 1. However, 2 do stand out, and that is NEMIX and WITMIX, which appear or have significantly improved overall survival in the current cohort compared with last time, for reasons that we don't necessarily know. Next slide. This is just a bit more granular data with the actual 1 year, 2 year survival rates for the different X. You can see, as we said, we've presented the overall statewide average. And if you look at the median survival times, again, these are less than you would typically see in studies, reflecting that this is real world data. And we know the real world data will always be inferior compared with clinical trial data, because the cohort that go into clinical trials are not really reflective of real life practice. Next slide. Then we've drilled down the survival data to try and understand this a little more. So we've got here the survival, again, forest plot of survival, exactly the same way. Greater than 1 means worse overall survival. Less than 1 means better overall survival. We've drilled it down into non-metastatic and metastatic settings. So if you remember from before, we had improved overall survival for WITMIX and NEMIX. We drill it down further. The improved overall survival is seen in the non-metastatic setting for WITMIX, not for NEMIX. And interestingly, there's improved overall survival for metastatic patients in the in NEMIX area. We don't know what accounts for that. We do know that whilst we do know that the medical oncology care is excellent in NEMIX, I'm not sure that's necessarily the explanation. Next slide, thanks. So now we move to end-of-life care. So so this has been an area that we didn't really collect a lot of data. We've made an effort to collect some data here. General guidelines for patients with metastatic or advanced cancer is that they receive a timely referral to specialist palliative care. Recommended target is more than 80%, and that they have an opportunity to undergo advanced care planning, and that we capture the medical treatment decision maker on admission. Next slide. So if we look at the data, so we are seeing minority of patients receiving referrals to palliative care in the early stage setting, but that does increase as we go through to the locally advanced or metastatic setting, but still not all patients in the metastatic setting having documentation of receiving a palliative care referral. Next slide. Then we attempted to look at the timeliness of palliative care referral. Now, there's some limitations with this analysis. So this is looking at inpatient palliative care referral. It's not looking the sort of model that Jenny was discussing, and certainly in my hospital, we've seen increasing opportunity for outpatient-based palliative care. It's not capturing community palliative care either. So there's definitely some limitations in terms of this. Nevertheless, timely palliative care defined as inpatient palliative care referral at least 3 months prior to death is low across all the ICs, potentially at least in part reflecting a resourcing issue in the palliative care setting. Next slide. And then if we look at outcomes in patients at end of life, we're seeing we looked here at the proportion of patients who had emergency admissions, and overall 54% of patients had emergency admissions within 30 days of death. Approximately 42% had emergency presentations within 30 days of death, and 42% had acute stays within 30 days prior to death. Next slide. So if we recap the consumer identified areas for improvement, so Rita and Cherie talked about access to patient advocacy appointments, the importance of communicating hope, supporting second opinions, identifying supportive care needs, and I think that's a great idea to have extra support and supportive care nurse. And also talked about access to genomic profiling and access to clinical trials. Next slide, thanks. So if we then summarize what we've observed from the data and variations we've observed in the data. So in terms of detection, WIC-NICS had a higher incidence rate by ICS of residence. In terms of presentation, majority of patients are seen quickly following referral. There are some variation in the referral pathways, with metropolitan centres perhaps getting more referrals from ED and regional centres getting more referrals from GPs. Next slide, please. Then if we look at the diagnosis and treatment planning, non-metastatic patients more likely to have surgery in NEMICS, less likely in GRICS. Non-metastatic patients more likely to receive radiotherapy in Barwon and Southwest. There's generally variation in the MDM participation rates, as Charles has said, not much improvement. So 73% of patients discussed in MDMs compared with a target of 85%. There's variation in supportive care screening for a population that commonly have supportive care needs, with a documented average of 36%, with a target of 80%. And as we discussed earlier, the consumer recommendation for advocacy and supporting second opinions. Next slide, please. In terms of treatment, there's some variation in timeliness of care if you compare time to diagnosis to chemo or chemoradiation or surgery. However, if we look at the range, whilst we may not meet the target, perhaps the range doesn't indicate too much of a problem. There's variation in surgical length of stay, with the outliers highlighted by X. The surgery volume tail has shrunk slightly compared with previously, although there's still some low volume campuses. The difference in resectability data reinforces the need for resectability reporting, as we discussed earlier. Next slide, please. And then in terms of the care after diagnosis and initial treatment, so surgery, chemo and radiation after non-metastatic diagnosis has improved. There's an increase in neoadjuvant and adjuvant chemotherapy since the previous summit. The consensus is that the low mortality rates following surgery would be considered world-class. We've got some unexplained variations, higher survival rates for NEMICS patients in the metastatic setting and WIC-NICS in the non-metastatic setting, and the point raised by the consumers in terms of access to genomic testing and trials. Next slide, please. And then at end-of-life care, accepting there are some limitations, with the quality of data that we've been able to obtain. So there's opportunities potentially to improve referral to palliative care, and certain timeliness of palliative care referral, and there's some variation in health service activities in the 30 days prior to death, where potentially there's an opportunity to improve patient experience at that time. Next slide, thanks. So then the working party has prioritised some unwarranted variations. So and we've commented on variation in the MDM participation rates, which are still lower than the target rate of 85%, and which haven't improved much. There's the consumer consideration of genomic profiling and access to clinical trials. Clearly, we've got an issue for a population that has high supportive care needs with relatively low rates of supportive care screening. Again, an area of importance identified by consumers. Next slide, please. In terms of timeliness of care, so we're not meeting the recommended targets, but we're not sure how much variation we're seeing around this issue. And then there's the issue in terms of the variation in palliative care referral rates, with not all patients being referred, and potentially some issues in terms of timeliness of palliative care referrals. Next slide, please. And so that's the end of the data presentation, and I'd just like to finish by acknowledging the support of the various people who've been involved in collecting the data and doing the data analysis, as well as the team that has been involved in setting up the Tumour Summit meeting. So thank you for your attention.